to be of added value to our program, educational program that the SSBMT providing to its members. We had a technical issue at the beginning with the connection, and Dr. Bassem Bairuti is supposed to be chairing the session. However, Bassem has a technical issue and he will join later. So meanwhile, and to catch up with our time, it's a pleasure to introduce one of our renowned speakers, eminent hematologist, Dr. George Cortes. Dr. Cortes is a professor and director of the Georgia Cancer Center at Augusta University, Augusta, Georgia. Dr. Cortes will be speaking tonight about this, how I treat CML who failed prior therapy. Dr. Cortes will be speaking for 25 minutes, and then we will have question and answers at the end. So please do not post your questions to the and distract the team at the present time. However, we'll be happy to receive your questions at the end. So keep your questions and post it in the Q&A corner. Cortes, please, the webinar is yours, and please go ahead.
Thank you very much. Thank you for the kind invitation, and thank you all of you for joining. I hope you're all safe with this pandemic that we're all living, and we're trying to get through this major problem. But it is a good thing that we have now these tools to communicate and to continue our academic activities, our ability to discuss and to exchange some ideas. I'm going to be talking to you about how I treat CML who have failed prior therapy. Many of you know me from my long career at MD Anderson. I just recently moved to this new institution to take some new responsibilities, but I continue my work in leukemia. I will start by reminding you that the outcome of CML patients is very good nowadays. A patient diagnosed with CML today, if they have good management, good access to the proper drugs, good monitoring, they can expect really a normal life expectancy. This is one study that we published from MD Anderson, and many others have shown the same thing. Now, this is unfortunately not universal. On the left here, you see how the survival expectation has improved dramatically in data from the MD Anderson. But on the right, you see the epidemiologic data in the community in the United States. So even within the United States, you can see that the progress has not been as good as you can expect when you have access to all the therapy and to the monitoring and proper care of the patients and all of that. So it is very important to remember that although we have the tools to make the outcome better for our patients, this has not reached every patient yet. And that is an important thing that we all need to keep in mind to try to improve the lives of our patients. Well, now today we're talking about the patients who have failed prior therapy. And sometimes we tend to think that this is not as common. But I'm showing you here the results of the 3 randomized studies that have been conducted with second-generation TKIs compared to imatinib. And what this table shows is the percentage of patients who have discontinued therapy for whatever reason. And as you can see, by 2 years, about 25 to 30% of patients have discontinued, even the second-generation TKIs. But by 5 years, almost 40% of patients have discontinued the second-generation TKIs. And by 10 years, half of the patients have discontinued nilotinib. So as good as we think that the second-generation inhibitors are, we still end up losing many patients, end up changing therapy. Some of them because of efficacy, some of them because of safety, some of them because of the physician's choice, whatever. And this is not elective treatment discontinuation for a good response. So evidently, many patients end up needing additional therapy. So you all know the recommendations from the European Leukemia Net. This is the new edition that we just published a few months ago, the 2020 recommendations. And you all know them very well, and they guide us as to how we should manage our patients. I don't know if you are seeing this thing, but I'm losing my slides on and off. I don't know if here we go. I want to highlight a couple of things here. One important change among the failures is this BCR-ABL more than 10%. Now, that is also one of the warnings. However, it is a warning, excuse me, it is a failure only if it is confirmed within 1 to 3 months. So one isolated determination is not enough to consider this a failure. And we're going to talk a little bit more about what to do with these patients. And another interesting thing here is that the new edition says that a BCR-ABL of more than 1% at any time is a failure. That essentially means that a patient does not have a complete cytogenetic response. And that's also something new for the recommendations of 2020. Well, let's review what we can do for patients who have failed one prior TKI. I'm going to give you 3 slides showing you the data for the second generation TKIs. And these 3 slides are on patients who received prior imatinib only, no other tyrosine kinase inhibitors. This is the dasatinib study. It has a long follow-up, 6 years of follow-up. And as you can see, the results are good. But it's also good to remember that only about 50% of patients achieve a complete cytogenetic response. That's a complete cytogenetic response, not molecular response. Molecular response, major molecular response, it's 46. But it is important to remember that even when a patient has only received imatinib previously, about half of the patients will have a complete cytogenetic response. It's a little bit better for the intolerant patients than for the resistant patients. The data with nilotinib is not that much different. The follow-up here is only 4 years. We haven't seen any more updates, but you can see how the complete cytogenetic response rate is also only 45%, very similar to the dasatinib data. Again, a little bit better for intolerant patients than for resistant patients. And then you have the bosutinib data. We have more follow-up on this study. This is an 8-year follow-up. But again, complete cytogenetic response in only about 50% of the patients. Again, maybe a little bit better with intolerant than with resistant. But you see the common theme. We think that we have very good second-generation TKIs, but at best, 50% of patients respond with a complete cytogenetic response, and much less if we're looking at the deeper molecular responses. We don't have much data with these studies because these are older studies. Now, which one of these 3 drugs is better? And they've never been compared head-to-head, so it is impossible to draw conclusions. But what I'm showing you here is the data from these same studies, extracting only the patients who had resistance to imatinib, not intolerance, just resistance. And I'm showing you the data at 2 years. And the reason I'm showing you the data at 2 years is because by then, all of the complete cytogenetic responses have been achieved. And number 2, because that is a time point where we have reports from all 3 studies. And as you can see, the rate of complete cytogenetic responses is very similar, around 40 to 44% of the patients. No difference there. The progression-free survival, very similar. The overall survival, very similar. So although we don't have a direct comparison between the 3 drugs, it appears that the 3 drugs are grossly equivalent. They all are equally good or equally bad if you consider that the complete cytogenetic response is less than 50% for all 3 drugs. One way to select then the drugs, since there doesn't seem to be a significant difference between the efficacy, is, we know, by following the mutations. And these are the recommendations by the European Leukemia Net. Of course, for T359, the only drug that we have today that works is ponatinib. For the 317 mutation, with this mutation, bosutinib doesn't work. So you have to use either nilotinib, bosutinib, or ponatinib. For the V299L, this is a mutation that is very rare. But if you have that, neither bosutinib nor dasatinib works, so nilotinib or ponatinib. And then for these other mutations here, nilotinib doesn't work, but dasatinib, bosutinib, or ponatinib work. These are really the only mutations where we have a clear difference between one inhibitor and the others. So these are the ones that can guide your treatment. So that means that it's only a small fraction of the mutations where we can use the mutation analysis to guide the response. Now, let me say a quick word about this mutation, E255B or K. This is the mutation that in vitro is least sensitive to the tyrosine kinase inhibitors after the T359. And we recently published data of clinical results of patients that have this mutation. We had 48 patients, 14 are chronic phase, 22 blast phase, 12 accelerated phase. But look at the results in the chronic phase, 14 patients. And you can see that 8 of these patients, more than half of these patients ended up transforming to accelerated phase and blast phase. 9 of them have died with a median survival of only 37 months, 3 years. So the outcome is very poor. In accelerated phase, no responses, only 1 hematologic response. In blast phase, there was a little bit of a response to TKIs plus chemotherapy, and the 3 patients that got a transplant are alive. Everybody else is dead. So it is important to remember that this mutation has a very poor outcome, and that is one mutation where I would say that if you see that, you should consider a transplant. No matter how many prior TKIs the patient has received, you don't have to wait until they have 2 or 3 or 4 tyrosine kinase inhibitors. Now, when you select the inhibitor according to the mutations, it is predictive of outcome. But remember that this is not true in all instances. It is predictive for a response in chronic phase and in accelerated phase. It's not predictive in blast phase. And for event-free survival, it is predictive in chronic phase, but it is not predictive in accelerated phase. And the reason for that is because in accelerated phase, and even more in blast phase, there are other molecular events that happen that make the mutation status and the BCR-ABL activity be not as prominent. Many times the disease is driven by other molecular abnormalities. So that is important to keep in mind. Now, you still would select the drug based on the TKI, based on the mutation, but it's not always going to be as predictive. Now, when do you look for mutations? If you look for a mutation when a patient has a suboptimal response or a warning, keep in mind that you're going to find mutations very rarely. Only about 5% of patients are going to have a mutation. Even in patients that have failure, if they lost the response, then 30 to 50% of patients are going to have a mutation. But if failure is not achieving the response, the definitions of the European Leukemia Net, only about 15 to 20% of patients are going to have a mutation. So you really need to look for a mutation when a patient has failure, and certainly when they have lost the response. But it's not worth looking at it when you have a warning. I never do that because the yield is so low. So with all of these, how do you select the TKI? Well, there are advantages and disadvantages. I'm not going to go through all the table here, but we know, some of the things that we know. The efficacy is good. The schedule, the dasatinib and bosutinib are once a day. That's easier for the patients. in the disadvantages are mostly the toxicities that are different. We're going to talk about that in a minute. The schedule for nilotinib and the high frequency of arterio-occlusive events with nilotinib and with dasatinib that makes you consider those if the patient has risk features for arterio-occlusive events. So this is how I see the selection of TKIs. And this is true whether it's newly diagnosed or after they have failed prior therapies. For example, if a patient has diabetes, I prefer not to use nilotinib. Now, I want to clarify, this doesn't mean it's contraindicated. Have I used nilotinib? Yes, of course. But if I have the choice to use one of the others, I think it's better because nilotinib brings up the glucose. If they have pulmonary disease or pulmonary hypertension, I prefer not to use dasatinib. They have GI issues, bosutinib causes more diarrhea. If they have cardiovascular risk factors, nilotinib and dasatinib have a high risk of cardiovascular arterio-occlusive events. Bosutinib has much less of that. And of course, imatinib even less. The same thing for peripheral arterial disease. For liver toxicity, bosutinib perhaps has a little bit more. The same thing with renal toxicity. So that can help you select depending on the characteristics and the comorbidities of your patients. One thing that can help when you're using bosutinib, especially for the diarrhea and to some extent with the liver toxicity, is to use an alternative way of doing the dosing. In this study that was presented at ASH last year, this is for patients that are age 60 or older who have received one prior TKI. And what they did is they started with 200 milligrams. Remember, the standard dose is 500. They started with 200. After 2 weeks, they increased to 300. And then at 3 months, if the BCR-ABL is less than 1, they stayed at 300. They didn't increase it anymore. If the BCR-ABL was more than 1%, they increased to 400. And they didn't go any higher. They did not attempt to go to the standard dose of 500 milligrams. But you can see the results are very good. We can focus on the 6 months because that's where we have more data. In the 12 months, there's a lot of patients who are still too early. But you can see that at 6 months, half of the patients have a major molecular response and a few more have a complete cytogenetic response. These results seem to be better than what I showed you earlier from the older studies. Look at here, the cumulative rate of major molecular response is 65%. So it looks like by doing this gradual dose escalation, you can optimize the therapy with bosutinib and make it better tolerated especially for the older patients. Now, what about intolerance? Those are the resistant patients. What about intolerance? One of the problems with intolerance is that the definition that has been used in the different studies is very different from one to the other. So it is impossible to compare the results from one study to the other. They all show a little bit better outcome for intolerant versus resistant, but there's a lot of variability between one study and the next. One way to look at this is to look at how many patients had cross-intolerance of the TKI. And when you're talking about cross-intolerance, you can talk about two things. One is how many patients discontinued the therapy, the second TKI, for the same toxicity that they discontinued the first TKI. So let's say they had diarrhea with imatinib, and now they discontinued the second TKI also with diarrhea. The other possibility is that they still had the same adverse event. It was grade 3 or 4, but we didn't stop the treatment. We didn't discontinue the therapy. So when we talk about discontinuation, you can see it's about 20%, maybe a little bit less cross-intolerance with bosutinib. When we talk about occurrence of grade 3 or 4 events, dasatinib has significantly more, whereas nilotinib has only about 55% and bosutinib 45%. So there seems to be a difference in the cross-intolerance, although that discontinuation and all of that is very subjective. It's very dependent on the physician's choice, so we need to keep that in mind. What about switching therapy when the patient has low-grade toxicities? Not intolerance, but the patient is feeling tired, the patient is having a little bit of chronic pain. The patient is having, these kind of low-grade toxicities that are uncomfortable, but they're not grade 3 or 4. Well, there was this study that we published some time ago, 52 patients that were on imatinib had grade 1 or 2 toxicity, and we switched them to nilotinib. As you can see, 60% of the adverse events resolved, but there were a few that actually worsened. In about 60% of patients, the patients said that all the symptoms improved. But keep in mind that 85% of patients had new nilotinib-related adverse events. 31% were actually grade 3. And 44% of patients had to dose reduce or interrupt the nilotinib because of the toxicity, and actually 15% discontinued. So there is a trade-off, and it's always very difficult to change because of these toxicities, because you could end up having worse toxicities. You remember, these are all grade 1 or 2, and now 30% of patients now have grade 3 toxicity. So you have to really very carefully assess that. So I really do not change toxicities. I educate the patients. I manage their expectations. For example, the fatigue. That's not always because of the TKI. It's many other reasons that cause the fatigue. Communicate frequently with the patients. They all have my email address. I help them manage their adverse events. Treat the adverse events. Give them something for pain, something for nausea, something that can help. Sometimes you can get the assistance of a nutritionist or a psychiatrist or a pain doctor, etc. Adjust the doses. That can be helpful in many patients. But I very, very seldom change the treatment with the TKI for these low-grade toxicities. Now, what about the third-line therapy? The patient has received now 2 TKIs, and you need to change. What are the results? Well, the data with some of the second-generation TKIs that is mostly from retrospective series and case reports and all of that. You see some of the series that have been published, mostly with nilotinib, dasatinib, and you can see the outcome is not very good. Only about 20 to 30% of patients have achieved a complete cytogenetic response. That's not a surprise because these drugs are equivalent. So if you fail the imatinib and nilotinib, giving them dasatinib is not going to help that much. Now with bosutinib, this series has a higher rate of response, so that is attractive. And actually, bosutinib is the only study, the only drug that has done a prospective third-line therapy study among the second-generation TKIs. The results don't look as good as I just showed you in the previous one that was retrospective. You do get about 30 to 40% of patients with a major cytogenetic response, but only about 14 to 28% with a complete cytogenetic response. Clearly, the best drug in the third-line setting is ponatinib. The response rate is very high, 59% major cytogenetic response. Most of these are complete cytogenetic response. Now, keep in mind, 95% of these patients had received at least 2 TKIs and 60% had received at least 3 TKIs. And we're already seeing major molecular responses and deeper responses. They're durable. So clearly, ponatinib is the most active drug in this setting. Of course, there are the concerns about arterial-occlusive events. I'm happy to talk about them in the questions, but I'm not going to dwell into that during this presentation. Now, so when you're going to change therapy, there are many things that you need to consider. Of course, what is available? Do you have the other TKIs, what TKIs, etc.? Do you have a donor for a stem cell transplant? All of these possibilities. The next one is, what is the expected efficacy, the realistic probability that the patient is going to respond to that? So you don't change just because you can, but will the patient really have a chance of responding better to that other drug? The other one is, what is the local experience? For example, with a transplant, what is the local experience with a transplant? If the experience is very good, that may be the best choice to use for a patient. Is the other option safe, depending on the comorbidities and the age and all of these? And what are the goals of the patient? Do they want to achieve treatment-free remission, or they just want to have a good quality of life. And it's also worth asking whether if the patient has a response that is not even a complete cytogenetic response, is that useful to the patient? And we did this analysis a long time ago, almost 10 years ago. And these are patients that with a second-line TKI had achieved either a complete cytogenetic response or something less. At those days, we didn't have that many options. So we said, what happens to them? And you can see that the survival and the transformation-free survival is still very decent, even for patients who only have a complete hematologic response. Certainly, if they have a minor response, cytogenetic response. So it's important to keep in mind that the patients do have a benefit, even if they have only a cytogenetic response. And if you're going to go to something that's much more risky, that may not be justified, and it may be better to stay with where you are. So you need to carefully analyze the patient. Well, this is my simple interpretation of the response, and unfortunately, this had some transition that is not happening here. But this is an equation that essentially, in simple terms, means that 1 + 1 = 2. My simple interpretation of the molecular response, and particularly in the second and in the third line, is that if the PCR is going down, it's okay. I don't worry too much about the deeper molecular responses and all those things in the second line. You know, these patients, they don't have as many options available. The timelines and all of those are not as critical. You want to get the patient stable and in a good response. Only if the results are going up and that's clearly confirmed, then you have to start considering different treatment options. So to summarize then, when do I change therapy? When there is an ELN failure. And that I say mostly because I don't do it at the 3-month mark. I'll show you the data in a minute. When the patient loses a complete cytogenetic response, absolutely. When the patient has intolerance, but I want to make sure that it's a true intolerance, that I've managed the adverse events, that I lowered the dose, that I've done everything I can to manage that toxicity. I do not change therapy if there's just an increase in the PCR. I do not change therapy because the PCR is still detectable. I do not change therapy for the first instance of an adverse event, except for very few circumstances. Now let's talk about that 3-month that we were talking about earlier in the more than 10%. Remember, I told you that in the 2020, the more than 10% is considered a failure if it is confirmed after 1 to 3 months. And it's also a warning the first time it occurs. It used to be only a warning in the 2013 version. Why is it a failure? Well, because we know that the patients that have more than 10% have a worse overall survival. You see that here on the left, and a worse event-free survival. These Hodge bars are the more than 10%. But I want to call to your attention that they still have a good outcome, 80% survival, 70% event-free survival. It's inferior, but most patients still do well. So keep that in mind. What happens if you don't change at 3 months? Well, this is our experience that we published some time ago, and we never changed at 3 months. So we waited until 6 months. Now, what happens here after 6 months? The patient has now achieved a less than 10%, which is equivalent to a major cytogenetic response. Look at their outcome. It's very good. Only the patients who still more than 10% now have a bit of a worse outcome, but still 2/3 have a good event-free survival. So even then, most patients still are going to do well. And part of the problem is we don't have data. The only study that addresses treatment at that stage is a very recent study that we published called the Cern trial. Patients with imatinib that at 3 months had more than 10% were randomized to receive dasatinib or continue imatinib. The primary endpoint was major molecular response at 12 months, and that was achieved. You see 29% versus 13%. These are the cumulative curves. It looks much better. But what did not change is the overall survival or the progression-free survival. Those are exactly the same. Now, the follow-up may be short. We need to wait, but clearly we have not made an impact in these outcomes. Now, of course, the other thing that is important is that you want to have a better chance of achieving a deep molecular response. So we clearly need longer follow-up, but today there's no evidence that this intervention alters the long-term outcome of patients. It improves a little bit the short-term outcome, the major molecular response at 12 months, but nothing else. So I'm going to skip this because it came all scrambled. So how do I manage these low responders? The most important thing is try to avoid them. Early on, optimize your therapy, minimize treatment interruptions, manage the adverse events. Do everything you can so the patient has the treatment the way it should be and gets to that response. If it is more than 10% at 3 months, I continue unchanged, unless there's really no complete hematologic responses. Optimize therapy. Maybe you dose reduce earlier. Well, make sure that you use the optimal dose. Is the patient really taking the drug? If at 6 months there's still more than 10%, may consider the change. If it is imatinib, if it is the dasatinib or nilotinib already, what are you going to change to? That is an important consideration. Now, I do want to introduce one new drug, asciminib, or ABL001, because I think this drug is going to be approved very soon. There's a randomized study going on. I don't know anything about the results, so I'm not telling you any secrets, but I think it's likely that it's going to be better. This is a new tyrosine kinase inhibitor. It's an allosteric inhibitor that binds in a different area, not in the ATP binding pocket like all the other inhibitors, but in this area that is the activation loop. Because of that, it is still very active against T359, whereas with nilotinib, you need very high concentrations. But there are other mutations that do not affect nilotinib that affect this drug, because they're the residues next to where it binds. You all have seen the results in the New England Journal of Medicine that we published a few months ago in patients that have received, more than 90% have received 2 or more tyrosine kinase inhibitors. The cytogenetic response major 77%, complete 70%. Even almost half of the patients have a major molecular response. Even patients with T359 have a good response, but keep in mind that they need a higher dose for the T359. The dose for T359 is much higher than for the non-T359, but there's no toxicity so far with that higher dose. There are other TKIs under development. I'll mention these 3, PF114, HQP1351, and KO706. They are all finishing phase 1. The first 2 have activity against T359. The last one does not have activity against T359, but it is effective against the other mutations. So keep an eye on those drugs. Now, what about transplant? We just recently published this paper where we looked at the database from the International Bone Marrow Transplant Registry and compared it to the patients from the MD Anderson that were treated with TKIs. And we calculated the residual life expectancy with transplant or with TKIs. And as you can see on the top, for chronic phase patients, there is more residual life expectancy with a TKI than with transplant. In accelerated phase, it is the same, 5 years and a little bit more. In blast phase, it's very poor with both, but certainly transplant is the better option. And we had published also something similar for the T359, now here using the European Bone Marrow Transplant Registry and the PACE results from the ponatinib, and we find the same results. Chronic phase, ponatinib does better. Accelerated phase, it's the same. Blast phase, both are bad, but transplant does better. Now, of course, these depends on being able to provide these options, and there may be other considerations that need to be taken in mind. The cost of transplant, for example, that may make it a much more valuable option in some settings. So when do I transplant a patient then? I don't transplant them in front line or even in second line. In third line, I think that once a patient moves to second line, you need to start at least looking for donors and assessing that option. And in some instances, depending on the mutation, the condition of the patient, the age, in some instances, I may transplant. Fourth line, more likely. Accelerated phase, if it's front line, never. If they transformed, then again, depending on the characteristics of the patient. In blast phase, certainly, you have to transplant, get them into hematologic response, and transplant right away. So a final word, I think that you need to remember, at least my opinion, is that being PCR positive is not a failure, and that's not a reason to change. These things at the more than 10% at 3 months, only in clinical trials. You need to make sure that you have something better to offer to the patient, not that you just have something else. It has to be something better. Don't be afraid of some of the side effects, the diarrhea and other things. These are things that can be managed. Don't be afraid about transplant. You need to evaluate carefully, but we sometimes let it go until fifth line and seventh line, and for some patients it should be done earlier if they're young and in good condition. And don't consider everything intolerance. We make sure that an intolerance is truly an intolerance. So to conclude, I'm going to finish with this quote from Confucius. This famous philosopher from China. He said, "Only the wisest and the stupidest of men never change." So with that, I will stop, and I thank you for your attention. And I'm sorry, this is the wrong email address. This is my old email address. I'm happy to let you to give you my email address. It's Jorge, JORGA.Cortes, CORTES @augusta.edu. Thank you very much for your attention.
Thank you very much, Dr. Cortes. Can you hear me, Dr. Cortes?
I can, thank you, yes.
Thank you. Nice to see you, nice to hear you again. We met 1 decade ago when you were at MD Anderson. I did spend 1 month at the Department of Leukemia at MD Anderson. And I have to say you are an excellent teacher, moving to another center as a director. I'm sure you will be an asset, and I wish you will have the continuation of being a teacher, for international candidates who will come from all over the world. Is this opportunity opened for international fellows who would like to spend time with you in your cancer center in
we don't have it yet, but I'm planning to open that, so I'll keep you updated.
Please, and you are a great teacher, Dr. Cortes, and you are a great physician. So without further delay, we will go to the questions, and if you allow me, I will start with the first question. Two parties here. How you will manage the manipulative patients? Some patients, they are not compliant, and you have to really use the policing or somehow to make sure that they are taking the medications absolutely on time every day before we say there is resistance. There's how you manage this. And the second is the pregnancy. And that's a big problem in Saudi Arabia. I would say many of our patients with CML, they are young. I have a couple of patients who are like in their 20s. They recently got married, and then she had the first pregnancy, finished, put her back on TKI, and she got pregnant again. And how you manage these two areas?
Yeah, those are interesting areas, unfortunately common, and particularly the first one is unfortunate that it's so common. And there's no universal way to manage that. But I think one important thing is to educate the patients well, let them understand exactly what they think. The problem with CML is that they don't feel any they don't feel any pain, they don't feel any symptoms from the disease. And so it's easy to switch the attention from the disease to the drug as the enemy. So I think it's important to keep reminding them what can happen if they don't take the drug, etc. I sometimes use examples like, the patients that I know are not taking the drug, I tell them, you know what happens to me if you don't take the drug? They say, well, I don't know, you get in trouble. I said, no, nothing happens to me. If you don't want to take it, don't take it. I'll be okay. You won't. Sometimes you have to be even a little bit more direct and a little more. It works in some, in others it doesn't. But I think it is the education component is very critical. The pregnancy, it's complicated, and here there's three possible scenarios that I can think of. One is the patient that is taking the TKI already and gets pregnant unexpectedly. They did not plan for the pregnancy. They did not discuss it with you. You have to stop the TKI. There is enough data that is teratogenic. Now, what I do is I intervene as little as possible during pregnancy. I don't worry if the PCR goes up. It is going to go up. I don't use interferon because although it is safe, it takes too long to work. So you don't really get too much benefit from the interferon, and the patient's going to have symptoms from fatigue and depression and all the side effects of interferon. So very, very rarely now the PCR is going to go up, but I don't worry. As soon as the baby is born, then you start the TKI. If it is a planned pregnancy, it's a little better because then you can try to drive the disease as deep as possible, the response, maybe, increase the doses or change to a second generation to try to get the best response and then stop. Again, the PCR may go up, but then I don't do anything. The most challenging one is the patient who's pregnant and during pregnancy is diagnosed with CML, because then you have a high white cell count, a big spleen, etc. I try to manage that with hydroxyurea, particularly in the first or second semester. Again, interferon takes too long to control even the count, so I prefer hydroxyurea, and I give them short courses of hydroxyurea. I don't keep them all the time. Just bring the counts down and then wait. In the third trimester, the TKI is safe. So if you need to, in the third trimester, you could start the TKI, or if not, as soon as the baby is born.
Thank you very much, Dr. Cortes. This question I posted on the board. This is from Dr. Binyam Osman. I have a young patient on nilotinib in MR3. I am unable to give him full dose due to elevated AST/ALT. On 450 milligram per day, his ALT/AST is below grade 3 toxicity. So what do you suggest?
Well, I think that is a good strategy. It's of course you need to monitor the patient, but first you need to minimize the toxicity. That seems to be working well, and then you have to adjust your expectations. Okay, it's going to take a little longer to get to the deeper response, or you may not get to the AMR 4.5. But if you maintain the AMR 3, then the patient's going to be fine. They're not going to die of the disease, and at least you have that disease under control. So I agree with that strategy, and I continue the same.
And the next also is, do you think omictaxine has a role in TKI refractory disease?
Yeah, I didn't talk about omictaxine because it's I think only approved in the U.S. and it does have a role, but the response rate is very modest. So I use it in patients where none of the TKIs can be used. One advantage with omictaxine is that it is very myelosuppressive, but other than that, it's very non-toxic. It doesn't have liver toxicity, it doesn't have cardiac toxicity, so it has that advantage. But the response is very modest. If you've used all the TKIs and you don't have an option for a transplant, sure, that's an option. There are some unique cases, but I use it very little.
Excellent. And
So,
another question here is, do you use interferon in combination with TKI when you are unable to give full dose of TKI?
Well, that's still an open question. In Europe, they are using, even as initial therapy, the combination, trying to get the deeper responses and all of that. When I've used it in the past for patients who are not getting a good response and added interferon, I didn't get too much of a benefit, so I don't use it. It is an option if you don't get a good response at all and you don't have an option to change. Is it worth trying? Perhaps, but I think that the expectation is not really very high. I don't think it works that much in that context.
Okay, I have a set of combinations which I came across, and I would like to hear your opinion, Dr. Cortes.
Okay.
The cases of CML with myelofibrosis, grade 3 on bone marrow biopsy, how you will manage? Will you give TKI plus interferon or immune modulating or ruxolitinib?
Well, I think interferon is an option there. Going back to the interferon has some role there. If the patient has a lot of splenomegaly or symptoms where ruxolitinib may help, I think that can be done. We did a study, not for myelofibrosis, but we did a study trying. There is some suggestion that the leukemic stem cell, the CML stem cell, is very dependent on JAK-STAT pathway. So we were adding it to patients that were not in deep molecular response to see if we could get to the deep molecular response. That didn't work, but what we did show is that they can be combined safely. So certainly for a patient like that, I could consider that. Now, what I would do is start the ruxolitinib at a low dose, maybe 5 twice a day or 10 milligrams at maximum twice a day, and depending on response and tolerability, see if you need to escalate. There is likely to be more myelosuppression, so you're going to have to balance a little bit the doses of both the drugs.
Okay, another combination is the CML with JAK2 positive. I did have couple of patients, and I didn't know what to do with JAK2, except that I will be watching for thrombosis. But do you treat them with a selective beta TKI rather than the first generation? How you will manage these patients?
Yeah, that's an interesting combination. There are a few described in the literature. I've seen a few myself as well, and typically there is a patient that has a great response in the CML but has persistent elevation of platelets. So if the platelets are not too high, I don't do anything. If the platelets are high, more than 1 million or something like that, I may give some hydroxyurea. If there's a high risk for thrombosis, you can add aspirin. But I wouldn't use ruxolitinib, for example, in that instance. The outcome doesn't seem to be any worse. Now, granted, there's no large experience, so you need to be careful. But it doesn't. None of my patients had a poor outcome. You just monitor the platelets and manage them as needed.
Thank you. This is another question. When you attempt TKI discontinuation for TFR, do you see the Destiny half dose for 1 year protocol to be more useful than abruptly stopping the drug?
Well, I haven't used it routinely. And of course, the potential benefit could be that you see less of that withdrawal syndrome. I think that for most patients, I would just stop whatever you are. Some patients feel scared about just stopping the TKI, and they prefer to go slowly. That's fine. It'll be good. So I've used it in that context more than anything. So it is a good strategy, but if I want to stop, if the patient meets the condition, I just stop.
Okay, another question. Oops. Are there patients who are intolerant to TKI? Is this a reality?
Yeah, but the true intolerance is only probably 5 to 7% of patients. There's a lot of patients that have grade 1, grade 2 toxicities, chronic toxicities. And granted, some of these can be uncomfortable. They're not serious, they're not life-threatening, which is usually when we call them grade 3 or 4, but they can be uncomfortable. The chronic swelling with imatinib, or the slight elevation of the glucose with nilotinib, or some chronic diarrhea 2 or 3 times a day with bosutinib. That's not intolerance, but for some patients that may be just bad enough.
Okay, this is the last question from Dr. Ahmed Saeed. What's your recommendations for TKI treatment during if patient is COVID-19 positive?
Well, that's very topical now. We have been collected. We have this organization, the International CML Foundation, and we have delegates in many parts of the world. So we've been getting reports weekly of what people are seeing in different countries, different regions of the world. And what we have seen is that the mortality rate is slightly higher than for the general population, but it's not as bad as for other cancers or for other hematologic malignancies. And the TKI does not seem to be an adverse feature. There's not one TKI that's worse or better than the other. And the patients can continue receiving the TKI through the process. Of course, if they're intubated or something, they cannot. But if they're just, having some respiratory symptoms, it looks like the patients can continue the TKI without that affecting their outcome. And granted, this is all observational from the reports and all of that, but we have collected more than 100 patients now. So we think that the experience we have collectively is representative.
Okay, thank you very much, Dr. Cortes. This was very delightful presentation. We learned a lot from your experience, and this is an announcement that the SSBMT webinar series will be every Saturday, and our next webinar will be on 22nd of August. It's a multiple myeloma. It's a hot debate, how I treat multiple myeloma post-auto transplant. Should we give consolidation, yes, with Dr. Saad Usnani, or no, with Dr. Vincent Rajkumar? I'm sure it will be a hot discussion. So we will watch and wait for you Saturday, 22nd of August. Thank you very much, Dr. Cortes, and we wish you to see you in Saudi Arabia. Thank you.
I'd love to be there. Hopefully, some of the time when all of this is resolved.
Thank you.
Thank you, everybody. Have a good night, a good evening.
Thank you. Good night.